So again, scanning views is basically what you're going to do with your transducer in order to get image. Okay, this is how you're going to scan the heart. And what you need to do, you need to go over this session thoroughly. And then once you start scanning, you need to develop a routine, uh, how you go about scanning. So what we're going to do, we're going to spend about 30 minutes this morning. We're going to try and probably we'll divide it into about two sessions. Um, what we're going to do, we're going to look at what we call the parasternal long axis view, how you position your probe or transducer to get the parasternal long axis view. What are the structures that you're going to see in the parasternal long axis view? We're going to look at the RV inflow view, how you position the probe to get the RV inflow view. And then what are the structures you're going to see in the RV inflow view? The parasternal short axis view, how are you going to position the probe to get the parasternal short axis view? What are the structures you're going to see? When we talk about the parasternal short axis view, we talk about the short axis view at the level of the aortic valve, short axis view at the level of the mitral valve, the papillary muscles, and the apex. Okay, so those are the short axis view. Then we move on to the apical views, apical 4-chamber, apical 2 chambers, apical 3 chambers, apical 5 chambers, and then we go on to the subcostal view, how you position the probe, what are the structures you expect to see in the subcostal views, and then the suprasternal notch view, how you position the probe and the images that you're expected to get. All right, so let's start with our parasternal long axis view. So with your transducer or the probe placed in the third or fourth interspace, that is the left third or fourth intercostal space. Each probe has a marker. It may be a little light button or it may be a little indentation. You're going to position that marker to the patient's right shoulder, and then you're going to try and adjust the probe to get an image looking like this. So this is what you want to see. Okay, so this is a parasternal long axis view. How you get this view, the left third or fourth intercostal space, you're going to put your transducer probe there. The marker is going to point towards the patient's right shoulder, and this is the image you're going to get. That's your right ventricle there, right ventricular cavity. That is your aortic valve. The aortic valve is closed because this is a diastolic frame. In diastole, the mitral valve is open and the aortic valve is closed. As mentioned before, all of our images are gated. So there's a 12 lead ECG, there's an ECG rhythm strip at the bottom, and this is a diastolic frame. So diastole is from the end of the T wave to the beginning of the QRS. So diastole will be from right there to there, and you can see that the marker is in diastole. The marker is in diastole. That's why your mitral valve is open and the aortic valve is closed. Again, your right ventricle, aortic valve. This is the left atrium. This is the mitral valve. This is the anterior mitral leaflet, and the posterior leaflet is right there. The mitral valve is open in diastole. This is the posterior wall. This is the left ventricular cavity, and this is your septum. So these are the structures that you're going to see in the parasternal long axis view. Again, the transducer is positioned in the left third or fourth intercostal space. The marker is towards the patient's right shoulder. You're going to adjust the probe, and this is the image you're going to see in diastole. Diastole because the mitral valve is open, aortic valve is closed, and when you look at your ECG, the marker is between the end of the T wave and the beginning of your QRS complex. All right, so again, these are the structures you're going to see: the right ventricle, the aortic valve, left atrium, the mitral valve, the anterior leaflet, the posterior wall, LV cavity, and the septum. All right, so in systole, the mitral valve is closed and the aortic valve is open. Systole is from the beginning of the QRS to the end of the T wave. You see the marker is right here, okay, as opposed to the diastolic frame where the marker is in diastole. In the systolic frame, the mitral valve is closed. In the parasternal long axis view, we measure the thickness of the septum, okay? Again, this is a diastolic frame. The mitral valve is open, the aortic valve is closed. So we measure the septum from one side to the next side, and we usually do our measurements at the tip of the mitral valve. This is the mitral valve. So if you drop a perpendicular straight down at the tip, then you measure the thickness of the septum. Okay. Again, the mitral valve is open. It's a diastolic frame. You measure the LV dimension in diastole from the end of the septum to the beginning of the posterior wall, left ventricular internal dimension in diastole, and then the posterior wall, you measure the thickness of the posterior wall from the upper posterior wall to where the posterior wall meets the pericardium. Okay, so these are measurements that you're going to do in diastole. These are diastolic measurements: the thickness of the septum, LV cavity size in diastole, and the posterior wall. Measurements are done at the tip of the mitral leaflet, and you're going to get this line should be perpendicular to the wall. All right. So again, in systole, the aortic valve is open, the mitral valve is closed. In systole, we're going to do certain measurements. All right. In systole, again, systole, the aortic valve is open, mitral valve is closed. No. So I put this measurement in systole, but this measurement should be actually in diastole. You're gonna measure the aortic the aortic root measurement. It should be a diastolic measurement. So you're gonna do that from the upper aortic wall straight down to the inner wall, okay? When you measure the aortic root dimension, we can measure it at the sinus of Valsalva. That's where you have the outpouching, or you can measure it at the sinotubular junction. That is where the ascending aorta meets the sinus. Okay, you have to say where you're measuring it because the measurements differs. The measurement differs, so you have to say where you're measuring the aortic root. So this is your aortic root right there. You're going to measure it in diastole, okay? So this is your aortic root, okay? From the, we call this the leading edge to leading edge, okay? So from the upper portion to the upper portion. Measured in diastole, and it's the aortic root, okay? You need to say where you're measuring your aortic root. Is it at the sinotubular junction? Remember, when you look at the aorta, when you get to the sinuses, the sinus sort of outpouch. There's an outpouching. Okay? So when you get to the sinus, there's an outpouching. So if you measure it from sinus to sinus, then it's going to be there. If you're measuring from a sinotubular junction, this is the tubular portion and this is the sinus. So you measure from the sinotubular junction, it's right there. Sinotubular, this is the tubular sinus. Sinotubular junction is this little point right there. You can see that this measurement is going to be different from this measurement. So you have to see where you're measuring your aortic root. Aortic root is measured in diastole. All right, very important. All right, so those are your diastolic measurement. Now we're going to look at our systolic measurement. Okay, so even though we say aortic root measurement in systole, it's done in diastole. The measurement that you're going to do in systole is the left atrial measurement. And the left atrial measurement is from leading edge, so it's from the top to leading edge, from to the top again. So from the top of your where your aorta meets the mitral valve, so or the top portion of the left atrium, so the leading edge to leading edge is a systolic measurement. It should be a perpendicular. I don't want to say any slanted thing. It should be perpendicular to the wall, and then you're going to measure the left ventricular internal dimension in systole. Measurement for this is done at the tip of the mitral valve, tip of the mitral valve. You're also going to do the left ventricular outflow tract diameter measurement. The left ventricular outflow diameter is measured just a little bit in front of the valve, a few millimeters, and it's from the blood tissue plane to the blood tissue plane should be a perpendicular line. So the measurements should be about right there. Okay, just a little bit in front of the valve, perpendicular line. I don't want to see any slanted line, and it's there. It's a very important measurement. Okay, so it should be done in all your studies. Okay, so from the blood tissue plane, so once you get that junction, a perpendicular should be drawn, and again from the blood tissue plane. Okay, this is your left ventricular outflow tract diameter, so LVOT diameter. That is a very important measurement we need when we're measuring the aortic valve area, or if we're going to measure the stroke volume across the LVOT. Okay, very important measurement. All right, so those are your measurements you're going to do in systole. Now, in order to get your RV inflow view, so to get the parasternal long axis view, the transducer is at the left side of the sternum, third or fourth interspace. The marker is towards the patient's right shoulder, and you might have to move it up a little bit, move it down a little bit, rock it from side. You know the image that you're supposed to get in the parasternal long axis. Now to get the RV inflow view, with the transducer in the third or fourth interspace, you're gonna rock it downwards a little bit. You're gonna move it downwards a little bit, and you're gonna get the RV inflow view. This is called the RV inflow because you can see this is the right atrium below, this is the right ventricle above, and the tricuspid valve is right there. This is the posterior leaflet of the tricuspid valve. This is the anterior leaflet of the tricuspid valve. So it's showing you the blood flowing from the right atrium into the right ventricle. Hence it's called a RV inflow view. Okay? So again, the transducer is in the third or fourth interspace, the left side of the sternum, and you're going to pull it downwards a little bit. And this is the image you're going to get, the tricuspid valve. This is the anterior leaflet over here. This is the posterior leaflet. This is the right atrium right there. Okay, this is the right ventricle. The coronary sinus is about right there. And then just above that, you have the entry of the inferior vena cava. So the inferior vena cava enters the right atrium right about there. Just below that, you have the coronary sinus, and then this is the eustachian valve. Sometimes the eustachian valve is a little bit prominent. Okay, so this is your RV inflow view. All right. I will give you guys. We actually had a live demonstration of this, and I'll give you access to it as well. Now, from the parasternal long axis view, again, so remember to get the parasternal long axis, the transducer is in the third or fourth left intercostal space. The marker is pointing towards the right shoulder. You're going to clockwise rotate your transducer. You're going to clockwise rotate it, and when you get to the 1 or 2 o'clock position, you're going to tilt the transducer downward. So you need to develop your protocol. When you tilt it downward, you're going to get the apex of the heart, okay? And then once you tilt it upwards now, gradually tilting it upwards, you're going to move from the apex to the mid cavity, and then to the base, and then to the short axis at the level of the aorta. So it is gradual, and when you're doing echo, is no abrupt movement. It's very fine, precise, careful movements. Okay, these movements are not abrupt. So if you don't have good skills with your hands, you're not going to be able to do echo. It's fine, deliberate movement. So everything starts from the parasternal long axis view. So you're going to get the short axis view at the level of the aorta. Okay, the transducer is rotated clockwise from the parasternal long axis view. Okay, so remember, third or fourth intercostal space, transducer markers towards the right shoulder. You're going to turn the transducer clockwise, okay, to about the 1 or 2 o'clock position. The transducer is now tilted downward. So if the transducer is tilted downward, the face of the transducer is looking upward. So it's going to look at the aorta, okay? And you're going to have to still do a little bit of adjustments. You know, this is not an exact science. So you have to know, in your mind's eye, you have to know the image that you're trying to achieve, and then you do minuscule adjustments to get it. So at the short axis at the level of the aortic valve, you're going to get something looking like this. So this is the aortic valve is right inside there. This is the aorta. In systole, the aortic valve is open. The aortic valve opens in a triangular fashion. Okay? When the aortic valve opens, it opens in a triangular fashion. Again, this is the aorta. The aortic valve is inside the aorta. To the left, you're going to have the tricuspid valve. To the right, you're going to have the pulmonic valve. This is short axis at the level of the aorta. All right. So again, to the left, this is a tricuspid valve. This leaflet of the tricuspid valve is the septal leaflet. This is the anterior leaflet. This is your right ventricle. Your right ventricular outflow tract is right here. Right ventricular outflow tract. Okay. Again, your tricuspid valve is here. Septal leaflet, anterior leaflet, and then this is your right atrium. Okay. Remember that right atrium, blood is going to flow from the right atrium across the tricuspid valve into your right ventricle, which is right there. This is your right ventricular outflow tract is right here. The pulmonic valve is right there. Okay. This is a diastolic frame where the aortic valve closes. When the aortic valve closes, it closes in a Mercedes-Benz configuration. The normal aortic valve has 3 leaflets. Okay, 1, 2, 3. Again, short axis at the level of the aorta, diastolic frame. This is your right ventricle up there, right ventricular flow tract, pulmonic valve, main pulmonary trunk. This is your tricuspid valve. This is the right atrium. This is your atrial septum. Atrial septum. The atrial septum usually abuts the non-coronary cusp of the tricuspid valve. So this is your non-coronary cusp. Then this would be the right coronary cusp, and this is the left coronary cusp. Okay. Again, short axis at the level of the aorta. Your right ventricular flow tract, pulmonic valve, aortic valve opens in systole. Left atrium is right there. Your atrial septum, remember the coronary cusp, which is adjacent to the atrial septum, is your non-coronary cusp. The right is over there and the left is right there. That's your right atrium, tricuspid valve. All right. So your transducer was pointing downwards with the face of the transducer pointing upwards. To get the short axis at the level of the mitral valve, you're going to tilt the angle of the transducer upwards a little bit. So from the previous position, the transducer is tilted upwards just a little bit and adjusted to obtain the image. So again, remember these movements are very minuscule, very small movements. Okay, it's not abrupt type of thing. So you have to have finesse when you're doing echo. Okay, so you're doing the short axis now at the level of the mitral valve level, and we call this the base, at the level of the base or the mitral valve. So again, short axis. This is your mitral valve inside there. Anterior mitral leaflet is on top. Posterior leaflet is down the bottom. This is the anterior wall right up here. This is, and we're going to go over the walls, but this is the anterior wall up here. This is the inferior wall. This is the lateral wall, and the septal wall is right there. We divide our anterior wall into an anterior septal wall and an inferior lateral wall. Sorry, this is anterior lateral wall. Okay, we're gonna go over that, so don't worry about it. But we're just gonna name it. This is anterior lateral wall. This is our inferior lateral wall. This is the inferior wall. So again, all of this is the septal wall, but you can divide it into inferior septal and an anterior septal, and this is the anterior wall. So short axis at the level of the mitral valve. It's a systolic frame, so the mitral valve is closed. The mitral valve is closed. In the diastolic frame, the mitral valve is open. So the mitral valve opens with a little fish mouth type of thing. Okay, this is short axis at the level of the mitral valve. You put in the angle, the angle of the transducer is now moving upwards. So therefore the face is moving downwards. So again, this is your anterior wall, inferior wall there. This is the lateral wall over here. The septal wall is right there. This is your right ventricle up here. Okay. Okay. Again, short axis is the level of the mitral valve. It's a diastolic frame. The mitral valve is open. Okay. ECG is on the bottom. Remember, echo is gated. Echo is gated. It's either systole or diastole. You can see the marker is right there, which is between the T wave and the QRS. So it says in diastole. The mitral valve is usually open in diastole. The septal wall is right here. This up here is the anterior wall. Okay, the LV cavity is right there. The right ventricle is right there. Okay. Now, in order to get short axis at the papillary muscle, you have to move the transducer even the angle of the transducer even more upwards. Okay, so the transducer is tilted further upwards from the previous position, and you're gonna adjust to obtain the image. So remember, you always have to adjust, because you're not gonna get the exact image. These are small, minuscule movements. Okay, nothing abrupt. Okay, so this is short axis at the level of the papillary muscles. So these little humps are papillary muscles. Okay, previous position, you had the mitral valve. You're moving the transducer angle further upwards now, so you get short axis at the level of the papillary muscles. This is your anterior lateral papillary muscle. Anterior lateral papillary muscle. This is your posterior medial papillary muscle. Okay, short axis at the level of the papillary muscle. So we call this the mid. So when you get the mitral valve, that is at the base, and then this is at the mid cavitary level. Okay, so posterior medial papillary muscle, anterior lateral papillary muscle. All right, and if you move the transducer angle even further upwards more, you're going to get the apex of the heart. So this is the apex of the heart. So the transducer is tilted even further upwards from the previous position, and you're going to adjust it to obtain this image. So this is the apex of the heart. This is the anterior wall, inferior wall, the lateral wall, and the septum is over there. Okay, this is the apex of the heart. So what we have just done is look at the parasternal long axis view, the right ventricular inflow view, short axis at the level of the aortic valve, short axis at the level of the mitral valve, short axis at the level of the papillary muscles, and short axis at the level of the apex. Now, we're going to go on to the four chamber views. So, in order to get to the four chamber view, you're gonna take your transducer, and whenever you're doing image, you always have to put some gel on the transducer lens, a little bit of gel on the transducer lens, and that allows the ultrasound to travel freely from the transducer into the tissue. Okay, you try to eliminate any hair in between the transducer and the tissue. Okay, because remember, you're sending out ultrasound wave and you don't want it to travel through, remember it travels very slowly through hair. So if you have something like a gel, the transmission will be very rapid. Okay, so that's why you put a little gel. Now to get the apical four chamber view, you're going to put your transducer in the fourth or fifth interspace. Remember, now you know how to determine the interspace. Okay, so the fourth or fifth intercostal space, and the marker on the transducer is going to be at the 4 or 5 o'clock position. You're going to tilt it and adjust it, and you're going to try and get these images. So to get the apical 4-chamber view, which looks like this, the transducer or the probe is positioned into the 4th or 5th intercostal space at the mid clavicular line or at the apex. So it's usually at the junction at the mid clavicular line, where we already went over all of that in our anatomy session. So at the junction of the mid clavicular line or the 4th or 5th intercostal space, the marker, the transducer is going to point towards the 4 or 5 o'clock position. If the patient have an enlarged heart, then you have to move the transducer to the patient's apex. You're going to go more lateral, okay? And this is the image you want to obtain, okay? This is your apical 4-chamber. The heart has to stand vertically straight up. If the heart is tilted, you're not in the correct position. And we do not accept images like that. So the heart has to stand vertically upright like this. Okay? Apical 4-chamber view. The transducer is positioned in the 4th or 5th intercostal space, mid-clavicular line, and the marker is at the 4 or 5 o'clock position. Sorry, this is a systolic frame. All right, so again, your ECG always have to be there. Systole is from the beginning of the QRS to the T wave. Systole because the mitral valve is closed. And then diastole, the mitral valve is open, and you can see now your mark is between the T wave and or just right at the QRS complex. All right, so apical 4-chamber view, that's your left ventricular cavity. That's the mitral valve. So this is your anterior mitral leaflet right there. The posterior leaflet is right there. That's the left atrium right there. That's your descending aorta. Very important. This is the descending aorta right there. This is your atrial septum. This is your right atrium. Tricuspid valve. This is the septal leaflet, and the anterior leaflet is right there. That's the right ventricular cavity, and this is your ventricular septum. Ventricular septum is right there. Now, that is your apical 4-chamber view. To get to the 2-chamber view, apical 2-chamber view, from that position, you're gonna rotate the transducer counterclockwise. Counterclockwise. Not clockwise, counterclockwise. And you're gonna get your 2-chamber view. You might have to adjust the transducer a little bit to get the picture that you're supposed to get. And the picture you want to get is something looking like this. Okay? So from the apical 4-chamber view, you're going to counterclockwise rotate the transducer. And again, small, minuscule movements. And this is the picture you're supposed to get. This is the inferior wall now. Inferior wall, this is a very important view. Inferior wall and your anterior wall. Okay? Anterior wall, LV cavity, mitral valve, left atrium, inferior wall. Counterclockwise rotation. Now, in order to get the 3-chamber view, you just you're going to rotate it further counterclockwise. Again, very small, minuscule movements. So the transducer is turned further counterclockwise. You're going to tilt it from the apical 2-chamber view. You're going to adjust it a little bit, and this is what you're going to get. This is your apical 3-chamber view, because you have the left ventricular cavity, the left atrium, and now you open the aorta. You have the aortic valve and the aorta right there. This is the apical 3-chamber view. Very important view again. This is your anterior septal wall. That's the LV cavity. That's your aortic valve, aorta and aortic valve is right there. Left atrium is right there. Mitral valve and the inferior wall. So that's your apical three-chamber view. To get your apical five-chamber view, so we need to look at the apical five-chamber view. So what you do in order to get apical five-chamber view, first when you get your apical four-chamber view, when you get your apical four-chamber view, and again to get your apical four-chamber view, the transducer is positioned in the fourth or fifth intercostal space along the mid-clavicular line if the patient's heart is not enlarged, and you get your apical four-chamber view. To get the apical five-chamber view, you just rock the transducer downwards a little bit. So from the four-chamber view, the transducer, tilt the transducer downward, and this is the image you're supposed to get. Okay, five-chamber view, because now you can see the aortic valve and the ascending aorta. Very important view, especially when you're doing evaluation of the aortic valve and you want to calculate your aortic valve area. You want to get the aortic valve area. The five-chamber view is very important. So that is your mitral valve. This the anterior mitral leaflet is right here. Anterior mitral leaflet. The posterior leaflet is right there. Okay. This is pulmonary. This is the pulmonary vein. So it's actually, we said left lower, it's actually the left upper is right there. And this is your right upper pulmonary vein, not lower. Okay. This is the aortic valve right there, aortic valve, and then your aortic, your aortic root going into the ascending aorta is right there, anterior mitral leaflet. Okay. Now, you can see over this side, this is a moderator band. So this is one of the few views which allow visualization of the moderator band. Okay. And again, your ventricular septum, the apex, LV apex, the lateral wall. So this is your apical five-chamber view. So if you can do an excellent echo up to this point, you have completed 80% of the study. 80% of the study. There are two more views, the subcostal and suprasternal notch view, where we're gonna leave those views for our next session. But you know, this is a basic echo. Okay, you have to know how to obtain the views, and you have to know where to position the transducer to obtain these views. Not only that, you have to know what the views look like. You have to know what you're looking for. If you don't know what you're looking for, you're gonna do all sort of rubbish. So you need, first of all, to know exactly what you're looking for, know where to position your transducer, know how to move the transducer, and then you will get your views. You also need to know the structures that you're supposed to encounter in these views, and you have to know the views. All right. So just one other thing, okay. So in our parasternal long axis view, okay, I don't think I pointed out to you guys, but the descending aorta in the parasternal long axis view is located. Let me show you where it's located, because you have to be able to identify everything. Okay, so in the parasternal long axis view, okay, in the parasternal long axis view, your descending aorta is usually somewhere around right here. Okay, the descending aorta is usually around somewhere around there. So descending aorta is usually around there, around there. Uh, you actually saw it a little bit better in the short axis view. So it's usually descending aorta is usually right there. And if it's enlarged, you can quickly see it. I mean, and you should measure it. If there is any question about aortic aneurysm, dilatation of the aorta, and you can see it and measure it, you should measure it. Okay. Um, but in the short axis view, so this is your descending aorta right down there. So descending aorta. Okay.